Next presentation is by Dr. Shannon, hidden from Medicine 5.
Good morning all, I am presenting on behalf of Medicine 5, Hidden. This is a 49 years old female patient, Mrs. Sun, from Bangalore, is admitted in the ward with chief complaints of increased frequency of micturition for the past 2 weeks, intermittent fever for past 2 weeks, and left flank pain for the past 2 weeks. History of presenting illness. She was apparently well before 3 weeks back when she developed increased frequency of micturition, about 8 to 10 times per day, not associated with dysuria or frothing of urine. She also had hematuria 1 week back. The fever was high grade, intermittent, associated with chills and rigor, relieved with paracetamol. She also complained of left flank pain for 2 weeks, intermittent, no radiation of pain, no aggravating or relieving factors. Past history. She was a known case of hypothyroidism for the past 6 months on tablet eltroxin 50 mics. She noticed varicose veins before 5 months. The personal history wise, no history of loss of appetite, loss of weight present about 10 kgs in the last 6 months. She had normal bowel habits. Postmenopausal for the past 7 years, she was sterilized. Family history, no history of any similar complaints in family. Family history, no history of any malignancy in family. On examination, her heart rate, pulse rate is 104, blood pressure 140/90, respirate 24 per minute, saturation she was 98% on room air. Pallor present, pitting pale edema with hyperpigmentation present on the medial aspect of both chin. No icterus, clubbing, cyanosis, lymphadenopathy. Her JVP was normal. On abdomen wise, soft, not distented, left renal angle tenderness present, no free fluid. Respiratory system CVS and CNS examination was insignificant. So the differentials we consider the urinary tract infection, obstructive uropathy due to calculi, tumors, renal vein thrombosis, renal infarction, and glomerulonephritis. So we did our routine investigations. It shows hemoglobin initially 8.54, and there was a drop in hemoglobin because we considered it due to hematuria. Total counts 9,600, platelets was 1,81,000. And electrolyte wise, is bicarb was initially it was 21. While during the course in the ward, bicarb was falling. It was possible due to metabolic acidosis. We treated her for that. And creatinine was also rising in the ward. Initially, it was 1.20 presentation. But during the course of the ward, the creatinine was rising to 2.62. In the end, it was 5.19. So urine routine shows 276 WBCs, and his urine culture has also grown as Pseudomonas aeruginosa. We started her with meropenem. We consider Enterococcus as possible contaminant. We didn't treat for her for that. So we initially thought this problem as a probable acute pyelonephritis, and we started her with antibiotics. But her condition did not improve. She still had hematuria. Creatinine was also rising. So we did an ultrasound abdomen. It shows bilateral HUN. So the ultrasound abdomen shows the picture bilateral HUN. So it also shows some increased vascularity in the right adnexa. So we delineated further. We did a CT abdomen. It shows bulky bilateral adnexa. So with hyperdense lesion in the left adnexa, there is multiple diaphragmatic, periportal, paraiotic, parailiac, and external iliac lymphadenopathy. So it's bilateral moderate HUN. So this is some bilateral adnexal mass causing HUN suspected. So delineate, we consider the differential for this as some congenital causes of bilateral HUN, some congenital stricture of external urethral meatus, congenital posterior urethral valve. But for this patient, we considered there may be some as a old age patient, so carcinoma cervix, carcinoma bladder. So these possibilities is considered, and patients also have a bilateral adnexal mass. To delineate the mass further, we did an MRI of the abdomen. It shows a left-sided breast mass 3x3 in the left outer quadrant. Actually, for this finding we missed in the clinical examination, so we went we retrospectively examined the patient. We found a 3x3 cross breast mass sitting in the left outer lower quadrant. So this MRI abdomen also shows bilateral moderate hydrouretronephrosis, bulky ovaries bilaterally. There's multiple lymphadenopathy and thickening of a segment of rectosigmoid colon abutting bulky ovaries. Probable serosal filtration. There is mild ascites also present. So the patient doesn't have any family history of any malignancy. He is having a breast mass with multiple ovaries, multiple ovarian mass. So our working diagnosis is now probable breast malignancy with bilateral ovary mass probable of Krukenberg tumor. So our working diagnosis is like that it may be a possible primary at the same time primary malignancy, breast malignancy and primary ovary malignancy may be there. But our working diagnosis, because of no family history, we took it as primary breast malignancy with possible abdominal mets and Krukenberg tumor. So we plan to do a biopsy. We did a biopsy yesterday, but the reports are awaited. So our landing point is Krukenberg tumor.
Can you please go back? Why does she have lots of lymph nodes? Diaphragm, very potent, paralytic, hydrocare, retrocare, something like that. Could you explain that?
Maybe mets from breast. Retrograde.
How often does breast cancer spread to intra-abdominal?
Because it's causing Krukenberg's tumor, it shows the transilemic spread and it's retrograde lymphatics is not approved, so it may be transilemic spread or retrograde lymphatics.
Krukenberg tumor is because of transilemic spread, not pure lymphatic.
Should I read like it may be not it's proved actually it may be transilemic spread or retrograde lymphatics.
So this is a well-described finding in Krukenberg tumor. Extensive lymphadenopathy.
Maybe.
This is an MRI abdomen that picked up a left breast mass.
Yes, sir.
Did we proceed by doing an ultrasound breast axilla or a mammography, any local nodes?
We have planned to do that, sir.
Before that, the biopsy was done.
Biopsy done, sir.
Biopsy of which? What?
Biopsy of the breast.
Without doing an ultrasound breast axilla, without looking for axillary nodes, we biopsy the breast mass. Okay. What are the tumor markers in this patient?
Tumor markers actually we have sent CA 125. Report is awaited.
CA? Can this be a colonic malignancy? Asking did he send a CA? Is there a thickening of a? This is a common problem that happens. Is it a primary ovary? Is it a primary colon?
It's a best. We're planning to send, but before after getting the report of biopsy of breast, we're planning to do further workups. We're planning for gastroscopy, colonoscopy also, but waiting for this report of breast biopsy.
And clinical examination, did she have an axillary node when we went back and examined?
No lymph nodes, sir.
So that's the concern here, no? So breast mass with no local lymphatic spread, lymphatically spread and caused intra-abdominal lymphadenopathy. The breast mass is, we don't even know it's a malignancy, but we don't know the ultrasound characterization. I don't know how good is MRI to assess the breast mass. MRI well done is good, but this is an abdomen sequence where they have just got it.
So maybe a primary ovary also, but our working diagnosis like this. We are planning.
Post-menopause.
Post-menopause.
How frequent is ovarian cancer in post-menopause?
Might be worthwhile sending a CA.
So what we know is that this lady has bilateral HUN.
Yes.
Bilateral adnexal mass.
Yes, sir. Bilateral adnexal mass.
And it's a breast lump without. It's not a fixed lump, and there are no.
It's a hard mass.
Hard mass.
Shannon,
6.9.
a breast mass doesn't mean it's always a primary. There can be metastasis to breast also that we can see. So you have to look at where locally the disease you're seeing. It's predominantly abdomen. That's why everyone is saying it could be more like a GI malignancy.
Yes, ma'am.
Did we sense two locals at all because HP was low?
Sorry, ma'am.
Did we sense two locals because HP was low?
Actually, she is having hematuria, ma'am.
No, she's had a post-menopause.
Yes, 8.5. After coming to for the past 1 week, she's on.
It's only 1 day. So why did she come with the HP that's she's post-menopause?
Yes, ma'am.
How things are not
Yes.
Shannon, I finish it off now, sir. Please don't say phimosis and BPH as differential diagnosis for bilateral HUN in the penis.
Oh, that's what me.
Just about to say, that's my finish it off.
So Krukenberg tumor. So common primary size for metastasis to the ovaries occur are from GAT most common, pylorus, colon, and rarely small intestine. So other sites are gallbladder, pancreas, breast, and rarely endometrial carcinoma. Mode of spread through retrograde lymphatics. Sometimes translymphatic spread also is there. So not yet proved how is the spread is there. So in this case, the ovarian tumor is usually bilateral with irregular surfaces. So peritoneal metastasis also may be there. It will cause ascites. There may be thickening of omentum if the omental spread is also there. So if you see that naked eye appearance, the ovaries capsule will remain intact. There will be no infiltration out of the ovary. So histologically, it looks there will be signet ring looking cells. I showed in the picture. There are case reports with breast cancers presenting as Krukenberg's tumor. There are this is case report presenting 17
reports by the extensive abnormal lymphadenopathy.
It's not like.
How is it spreading? Krukenberg tumor, how is the metastasis happening? How is the cancer cells going from the breast or the
It's a retrograde lymphatic spread.
So classical teaching is like a leaf falling in the wind, the cells falling down. So how are the lymphatics involved here?
Posterior some.
Is it a proven fact or just a hypothesis?
Hypothesis, not a proven what's houses.
One more point. Can you please read the first line in that abstract?
Krukenberg's tumor defined as metastatic adenocarcinoma to the ovary.
Metastatic
Adenocarcinoma.
adenocarcinoma to the ovary. So, majority of breast malignancies are adenocarcinomas?
No.
No. So, here if you look at your title, you only look at the word breast cancer. The title is breast cancer with signet ring cells. That is breast cancer cells with an adenocarcinoma morphology. Signet ring cells are adenocarcinoma. That is why they are going and forming Krukenberg's. Classical epithelial cell breast carcinoma do not classically present with Krukenberg's. Okay, that the reason is the definition given. It is a metastatic adenocarcinoma. Which is why we are thinking GI is more likely than an epithelial cell tumor. Here it is breast cancer, not breast cancer. It is breast cancer with signet ring cells. It is a very low proportion of breast cancer patients who can have a adenocarcinoma-like morphology. Yeah, and then they can. I mean, even then, it looks like it's quite a low.
So it's also a case report in a female ovarian metastasis from breast cancer mimicking a primary ovarian neoplasm. Actually, in this case, they have done a biopsy of the ovarian that was initially they suspected ovarian malignancy. So that biopsy they found it's like adenocarcinoma. The patient also had a breast cancer. So diagnosis Krukenberg's tumor.
Can I make one comment?
Yes.
You put the urine culture. Did this lady have a polycatheter, cystoscopy, any urological procedure done?
No, sir. After coming to for bilateral HUN, we have done a bilateral PCR. After coming to work.
Was it this urine culture was before the procedure?
Before the procedure.
So anybody has a polymicrobial urine culture, the interpretation is only one thing: contamination, urine collection. Okay, unless the patient had polycatheter, multiple urological procedures, PCR, stent. Okay, otherwise somebody from the community avoiding by themselves, no urological procedures as a polymicrobial urine culture. That means it's a contamination. So don't treat that. Okay, and pseudomonas aeruginosa is somebody from the community.
To reiterate Sir's words, Pseudomonas aeruginosa is not a professional pathogen, and when you see it in a urinary focus, look for instrumentation or look for an immunosuppressive state or a structural abnormality. Because it's not a professional pathogen, you're not expecting a community-acquired UTI in somebody who doesn't have a structural abnormality, doesn't have an instrumentation, or is profoundly immunosuppressed.